All right. Good morning, everyone. Good morning. Good morning. So I think we're going to get started. My name is Amanda Luck, and I am the Interim Co-Executive Director at African Services. As I'm sure most of you know, that we are a multi-service human rights agency in Harlem dedicated to assisting immigrants and refugees and asylees from across all the African diaspora. We also provide free and confidential health, housing, legal, social welfare, education, nutrition, and advocacy service, regardless of your immigration status or of your ability to pay. And again, welcome to our inaugural Service Symposium series, which is made possible by supporters like you. And of course, if you're feeling like you have some money burning in your pocket, please feel free to make a donation to ASC. Details are right here. Okay then, so I would love for us to get started now. We are thrilled to welcome Dr. Matthew Gartland, who's the director of the Massachusetts General Hospital in Boston. And he is the director of the Asylum Clinic at the Massachusetts General Hospital Center for Global Health and an instructor at Harvard Medical School. The Asylum Clinic is comprised of more than 50 volunteer clinicians who perform forensic medical and psychological evaluations of survivors of persecution and torture seeking asylum in the United States. Dr. Gartland founded the clinic in 2017 and continues his leadership supervising evaluations, training clinicians, and disseminating research on best practices in the field of asylum medicine. I'm so excited to hear Dr. Gartland on this, because we at African Services have many clients who are either applying for asylum or who have applied for asylum, and this is very much part of our daily practice. Dr. Gartland is also a member of the American Academy of Pediatrics Immigrant Health Specialist Interest Group. He has worked extensively around the world on projects related to pediatric HIV and primary care in Mexico, Kenya, Zambia, and Liberia. Dr. Gartland earned his BA from Harvard College and his MD from Vanderbilt University, and completed his residency in Internal Medicine and Pediatrics at Massachusetts General. He is an adult hospitalist at Brigham and Williams Hospital and a pediatric hospitalist at Newton-Wellesley Hospital. Dr. Matthew Gartland, again, thrilled, and I would love to hand it over to you and welcome you to African Services and our allies.
Great, thank you for the welcome. Hope everybody can hear me and see my slides. Thanks for the invitation to join you on this Valentine's Day. I wish my content were a little more holiday appropriate. I do want to warn people that we're going to be talking a little bit about violence in terms of the topic of asylum seekers. But I also think that this work is grounded in love. And I hope to close with some positive messages about the resilience that we see amongst asylum seekers that we care for. So here's my talk about documenting violence and what we call the forensic medical evaluation, which I'll talk more about. I don't have any disclosures to tell you about. So I want to first tell you a story about a trend that I'm sure you're seeing in New York as well, which is the migration of refugees and asylum seekers from Africa, particularly those coming through South and Central America to the southern US border. We'll talk a little bit about what a forensic medical evaluation is and the role of a clinician in participating in an asylum seeker's application. And then I'll try to connect these evaluations back to the work that you may do, whether that's in a clinical setting or a social service setting. So I want to start by telling you a story about somebody that I took care of in our clinic. I met a 40-year-old man. I'm going to not share the country that he's from in order to keep details about his case private. But he was from Africa, and I met him in immigration detention. So he was being held with a deportation order pending, and he was applying for asylum from that setting. So I drove about an hour to an immigration detention facility outside of Boston and sat down with him and spent about 2 hours hearing about his story and documenting medical findings. So at the age of 18, in his country of origin, he was conscripted into the military for mandatory military service. And the living conditions there were extremely poor. He became someone who advocated for better conditions, and that got him into a lot of trouble. So he was subjected to punishment and beatings on many occasions. And I would characterize the treatment that he received as torture. All sorts of different kinds of beatings with injuries, as well as positional torture, being tied up or suspended in positions intended to cause pain. And after he was in these positions, after he was held, he would experience long periods of time where he was feeling numbness and weakness in some of his limbs and extremities, and developed chronic pain and disabilities as a result of this. So during his military service, he actually saw some combat and was shot. And as a result of that, he suffered a disabling injury that made him unable to serve in that capacity, but he was kept in the military, and he was subjected to forced labor and frequent beatings. When he complained about his prolonged service, he was targeted by the government and actually taken to a military prison, where I would describe the conditions as subhuman. And after several months in this facility, he was remarkably able to escape. And he was able to escape on foot to a neighboring country. From that neighboring country, he went to a third country where he was able to secure a flight and a visa. And he flew to Brazil and started his journey across Central America, South and Central America. So this is actually a headline pulled from a Reuters piece in 2019, which, if you see on this map, the journey that this person took was very similar to the individual who I met. So this person was from Cameroon and traveled through Nigeria, ended up going to Ecuador. And Ecuador and Brazil tend to receive many migrants from Africa because of more open visa policies, which have changed a little bit around the pandemic, but the phenomenon still exists, and that's the starting point. And this person covered in this story went through 9 countries on their way to the US border. There were dangerous conditions along the way. They spent prolonged periods in immigration detention, in this case in Mexico, and were treated violently both by authorities along the way, as well as criminal groups that were targeting migrants on their course. So migration along this pathway can take months and at times years, depending on where people end up and the travel documents they're able to acquire. And it's really become the most prominent migration route, or a prominent migration route for African migrants. So looking at some statistics on this, this is a graph of African migrants who are apprehended at different places, so Europe, Mexico, and the United States. And you see this phenomenon, certainly in Europe, that we heard about in 2014, 2015, of people traveling on boats from North Africa, and they were often interdicted in places like Italy or Greece, and policies there began to turn people away and actually put people into migrant detention centers in places like Libya. And for those reasons, we've seen a dramatic decrease in people trying to get to Europe by boat. And at the same time, in 2019, we saw an increase in Africans traveling through Central America and ending up at the US-Mexico border. So in 2019, the number was 6,600 African migrants were apprehended at the border, and this was 10 times the number who had traveled in 2014, so just 5 years earlier. There was a significant interruption during the pandemic when borders were closed, both along the way and then, of course, prominently the US-Mexico border. But it has been ramped up in 2021, and we're finding the numbers pretty comparable to that period in 2019. That was the previous peak. There's obviously diverse factors that are driving people to leave, and I think many of you are familiar with those. I think the point that I would make is that it varies widely based on community. So it may be that there's political persecution or armed conflict, climate change, and lack of economic opportunity are certainly push factors. And then some people are traveling to reunite with family who have made the trip previously. The most common represented countries are listed here at the top: Cameroon, the Democratic Republic of Congo, Eritrea, Ghana, and Somalia. And in fact, for Cameroonians, Mexico was a more common place than Europe. So there were roughly 3,100 Cameroonians apprehended at the US-Mexico border versus 2,300 in Europe. So regionally, this phenomenon of trans-American migration is even more prominent among certain countries. I want to compare this to refugees. So we know that the refugee numbers are at historical lows, and that was certainly true even before the pandemic, towards the end of the last administration. In 2019, DRC was the most represented country. There were about 25,000 refugees admitted total, and DRC accounted for 43% of those. Eritrea is also on the list of sort of the top 5 countries, and so those 2 countries alone made up half of the refugees admitted. And the thing that I would say about the refugee pathway, so as the US was becoming less open to taking in refugees, we also saw that it's idiosyncratic. So the countries that they come from and the countries that people have opportunities to travel are really quite arbitrary and don't really represent the need or the largest refugee populations. And they're geopolitical. The reasons why certain countries are on this list or not on this list really have geopolitical grounds, in addition to sort of practical grounds and people's access to the UN structures and the US State Department structures to access asylum refugee process. So I think the decline in refugees coming in the formal refugee process also accounts for some of the increase in the trans-American migration. It's a good opportunity to step back and just do some definitions that I think you're familiar with, but to reemphasize, the refugee definition laid out by international law is somebody who's unwilling or unable to return to their home country because of a well-founded fear of persecution on account of several denoted groupings. So race, religion, nationality, political opinion, or membership in a particular social group. And that can be, that can catch lots of identities. LGBTQ identities are captured there. If somebody has a disability or a medical illness, like they're HIV positive, that may account for their persecution. People who are refugees are located outside the United States, and they have not firmly resettled in a third country. So they may be in a formal refugee camp or outside the refugee camp system. And as I mentioned, there's a geopolitical aspect to this. So they have to meet a definition of a special humanitarian concern to the United States. So for example, Syrian refugees may have been a group that was targeted for refugee resettlement in the last 5 years. An asylum seeker, on the other hand, has to meet the definition for a refugee, but they're already in the US or they're seeking admission at a port of entry. And this is a legal means of coming to the US-Mexico border or entering and presenting yourself at a port of entry, or if you come in on a student visa, presenting yourself to an asylum office. So is trans-American migration of Africans important? I mean, we talked about the numbers and they are increasing, but I would just point out there are 30 million IDPs or refugees within Africa. And so this is a drop in the bucket compared to a much bigger issue of how people flee persecution or conflict or climate change. Also, when we just look at the southern border of the US, Central Americans still make up the vast majority of people who present there. And so there were 270,000 Guatemalans who came to the US-Mexico border in 2019, compared to the 6,000 that were from all of the countries represented in Africa. On the other hand, I think the fact that this is a growing phenomenon and the fact that this added diversity to migrants really has no policy solution or no mechanisms for safety, I think make it important. So if you look at migrants at the southern border, there really is diversity of where they're from, the languages that they speak, what they're fleeing, and certainly the resources that they have. And I think, as you've experienced and you described, Amanda, in your work, asylum seekers are presenting to our clinics and our social service organizations. And this is a phenomenon that is growing. And in the last 2 weeks, I've seen three clients from different parts of Africa who are presenting, who all migrated across Central America. And of course, we see a lot of people who come by other means. So it's worth stating that there's 180,000 Africans that came in 2019 on student visas, work visas, through the lottery, or family-based visas. And we see lots of people who are similarly fleeing violence using some of those mechanisms to present to our clinic or other social services. I want to thank Sharon for bringing up a question in the chat, and I'll put a pin in some of these questions that we can get to, definitely, and I'd love to hear your voice as you want to ask your questions at the end. I'll save some time for that. So I'm going to shift a little bit and tell you about the MGH Asylum Clinic, and thanks, Amanda, for introducing this. As you introduced me. This is a clinic that was started in 2017. I was part of a founding group, and we provide forensic, medical, and psychological evaluations to survivors of persecution. So to break that down a little bit, forensic is pertaining to the legal system, and we're essentially receiving referrals from attorneys in the Boston area, mostly at nonprofit legal service organizations, but also at pro bono attorneys' offices or private immigration attorneys. We receive referrals of asylum seekers, and we perform a medical and/or psychological evaluation to look for evidence of prior trauma. And we write up a report, present this to the attorney that then submits that to the immigration office or court. And these can be hugely important to corroborate or substantiate people's claims of prior violence. So we have a volunteer-based system. We have clinicians from lots of different fields, from social workers who have experience in domestic violence to neurologists who work on traumatic brain injury. And we really try to piece together a diverse team that can meet the client's needs, who we see. We also work with wonderful interpreters, have had some really unique interpreter situations. We had a client who was deaf and needed a sign language interpreter plus a Haitian Creole interpreter, and we were able to accommodate that. And I think every client has unique needs, not just language, but how to make them comfortable in the environment where they need to share a really difficult story about their prior trauma. We have 150 volunteers who work with us. In the last 4.5 years, we've seen 400 clients from 61 countries, speaking 23 languages. So a really diverse group with lots of different kinds of claims. So the basis for their claims being political or social, really interesting and challenging diversity. We do single encounters with asylum seekers and that are really not about delivering medical care, but just doing the forensic piece. And then we refer folks for follow-up mental health and primary care from our clinic. Similar clinics exist around the country, a few notable ones in New York Medical College, Mount Sinai, Cornell, Columbia, NYU, and all of those have programs that you can utilize for forensic medical evaluations. Really great colleagues working in New York. I wanted to highlight the representation from across Africa at our clinic. So 23 countries in Africa we've seen clients from. The highest among those is Uganda. And I think that's mostly a demographic thing, that we have one of the largest, if not the largest, diaspora of Ugandans in the United States, in the Boston area. and I think also speaks to the persecution that people experience. We see a lot of LGBTQ asylum seekers from Uganda, as well as people who face political repression. But also it speaks to access. And so there are lots of countries where people can't access a flight to the US or aren't able to eventually make it to our clinic. And I think all of those kind of build into this phenomenon of where we see people from. We see a large group of Cameroonians, particularly Anglophone Cameroonians, and then you see Egypt and Nigeria, but lots of representation from other parts of the continent as well. So a third of our clients are from Africa, which I think is fairly unique. If you go to other parts of the country, I think that would be skewed much more heavily towards Central America in particular. So going back a little bit to the process of seeking asylum, I just want to differentiate between affirmative asylum and defensive asylum, and highlight that affirmative asylum is when people come in on a valid visa to the US and may be a student or a travel visa, and then they go to the immigration office and present themselves saying they have a well-founded fear to return. Those folks may wait years to have their hearing. And so attorneys would refer them to us. People who are in the defensive asylum process also have a valid claim and a legal claim to present themselves in the United States. They're often in detention. So whether that's at the border, they've been apprehended and put into detention. They're in deportation proceedings. It also could be somebody who's been living in the community for years or decades, who then gets put into deportation proceedings and presents a claim. Somebody who has a new claim. So if there's a new law in their country that discriminates against a certain group of people, then they may present themselves with a new claim. And so that's affirmative and defensive. A forensic evaluation is an unbiased assessment, and we're really looking for evidence. And that evidence can be physical, like scars. There may be skin findings. There may be musculoskeletal injuries or neurologic injuries. And then we're documenting a lot of post-traumatic stress disorder or symptoms associated with trauma. And then our job is to really effectively communicate evidence. We write a report. It's our role to educate, particularly the court, about the range of normal responses to trauma, but there's no single way that somebody who's experienced trauma should act or will present themselves. And especially that the absence of physical signs is not necessarily evidence that trauma didn't take place. Especially when people are talking about remote trauma happening years ago, they may not have scars from things that they experienced, or those scars may not be visible and they may be psychological. I also want to make the point that we're privileged to work with a lot of wonderful attorneys, and we get referrals to our clinic. But you see people who have experienced trauma and may have an asylum claim in lots of settings. I'm a pediatrician, and I know that kids come into the primary care clinic and their families have stories, and it's important to screen for trauma in that setting. Likewise, schools, social service organizations, migrant camps are all places where people need to be identified. And the key is to begin to recognize the signs of trauma and to screen for trauma. And then serve immediate needs. The highest priority is not necessarily to get a forensic evaluation, but to serve people's immediate social and medical needs, and then refer them to attorneys or resources in your community that can serve them. And then finally, recognize that they may need a bridge to a forensic evaluation. It's a really powerful tool that not a lot of people know about, but for families that flee without any documentation, without hospital records, they really may have no physical evidence of what they experienced. And so the medical evaluation can be a really important tool. This breaks down some of the kind of anatomy or the steps involved in the forensic medical evaluation. And so the heart of it is the trauma interview. And we work really hard to make people feel safe. And I'll talk a little bit more about that approach. But people share difficult details about their past. We get some background on their medical history, their social history, and then hear about specific episodes of trauma or abuse that help us to contextualize our physical and psychological findings. Most of our evaluations have a mental health component, around 90% of those, and we have both, somebody who does general medicine like myself. I do mental health evaluations, but we also have psychiatrists, psychologists, social workers who contribute to that work, assessing mental health burden. The physical signs, as I pointed out, there's a diversity of physical signs. Clearly, skin is one of the greatest markers that we have, and we learn a lot about the healing process and expected healing process for injuries in order to do our work. But then there's lots of other injuries, fractures, dislocations. Even if they've happened remotely, there are often signs that we can pick up on a really good medical evaluation. And then the documentation piece, we're essentially establishing a consistency. How consistent is the finding that we have on our evaluation with the story that's being told to us? And that's what we write up in our report. And then we talk a little bit about the harm that somebody expects if they are returned to their country. I include education in our work. We do education with the asylum seeker, often validating and sort of normalizing what they've experienced, but then educating the adjudicators and the attorneys really about the spectrum of response to trauma, what trauma looks like. When I work with children, for example, explaining what traumatic stress looks like in an 8-year-old, and talking a little bit about memory and trauma's direct effect on memory and why somebody may not remember details of a traumatic experience. So I want to tell a second story as a way to access a little more details about the exams that we do. And so this was another client who I saw. Likewise, I won't share some of the private details of this case, just use some examples. So this was a 50-year-old seen in our clinic setting this time, coming from the community, has been in the United States for a number of years. And the story that he told me was that he'd been arrested in his home country without any formal charges and held as a political prisoner. He was held for approximately a week, during which time he was repeatedly assaulted with physical and psychological torture. There was sleep deprivation, tactics designed to humiliate him, electrocution, beating, and again, suspension and being tied up in positions to induce pain. And this introduces an idea that we have a real challenge facing, which is the difference between acute trauma and remote trauma. And acute signs of trauma may be seen if you're encountering somebody who's a recent immigrant or somebody in a refugee camp or migrant camp setting. And I have some colleagues who investigate torture and work with Physicians for Human Rights around acute signs of torture. And so this is an example of something called falanga, which is a repeated blunt trauma to the bottom of the feet. And it's done specifically to induce pain and also to hide signs of torture. And so in the acute setting, you might see hemorrhage or bruising, see a lot of swelling and a lot of pain. And the picture on the left is somebody who experienced falanga within a couple of weeks' time. On the right, it becomes more challenging when you see things remotely. And often we're seeing people 5 years after their trauma or injury. But there's a good amount of research and literature to teach us about what these things look like 5 years down the line. And so this is a picture of the bottom of somebody's feet who experienced the same type of torture. And the finding here is these brownish macules, we call them, these brownish flat discolorations of the bottom of the feet. And this study cited that in all of the individuals they looked at, it was about 20 individuals, every single one of them had these brown spots or hyperpigmentation, which was probably related to inflammation following the injury and some deposition pigment there. So it's really important for our volunteers to educate ourselves about what trauma can look like and the whole spectrum. It can look like nothing. It can look like it's healed, but it also can have subtle things to pick up on. And that's where training really comes in. And that's where using some of the resources around forensic and medical evaluations is really important. So I mentioned that this case also involved some torture that was positional or using suspension. And as a result, I really had to learn a lot about what the practices of torture are locally and what potential injuries are from those mechanisms of torture. So this particular gentleman described episodes in which he was tied up with his hands and his feet behind his back, and he was suspended for long periods of time, and his arms were pulled back, putting a lot of strain on the shoulder joints and the bundle of nerves under the arm. And so the picture on the right shows some of the nerve complexes in the arm, and at the top of the arm is something called the brachial plexus. And you can sort of get a sense from that picture that when you stretch that area of the shoulder by lifting or pulling back on the arm with force or for a long period of time, you can damage some of the nerves. And this gentleman described weakness in his hands in particular, and he had some loss of muscle mass in some of his major arm muscle groups, which is a sign of loss of nerve connection to those muscles. And then he also described sensory deficits, so some numbness and tingling. And when we examined him, there was a specific pattern to sensory loss, which connected it to some of the nerves from the same bundle. And then he was describing nerve-like pain, an electric shock that would go down his arm that was really characteristic and in a specific distribution that connected it to this peripheral nerve that came off of the brachial plexus. So I went to one of the resources that I use quite frequently, the Istanbul Protocol, and this is it's called the Manual of Effective Investigation of Torture and Other Cruel and Inhuman or Degrading Treatment or Punishment. And this was put together by the United Nations in a working group probably about 2 decades ago now, a little more than 2 decades ago, and has been updated a little since then. And it describes a lot of common techniques of torture and common harm that comes from this. And so I went right to the book to say, look for suspension injuries. And they talk about brachial plexus injuries, and the description that they give of injuries, damage to this plexus of nerves, leading to issues in specific distributions in the arms and hands. And this matched almost exactly what my client had experienced. And so I was able to write in my report that his description of symptoms and my examination was highly consistent, or actually diagnostic of this particular type of torture. And that was really strong evidence for that particular case. So it's important that we educate ourselves as we go into this. Now, if you're not a clinician and you're meeting people sort of at the front lines, it's not an expectation that you go into these sorts of details. I think the expectation is that you're aware that referring people for forensic evaluation and really good medical and psychological evaluation is an important step that can dramatically change the outcome of their case. I want to finish up with one of the areas that my general medical practice has most benefited from this work. And that's around trauma-informed care, or a trauma-informed approach to the forensic medical evaluation. So when we do these evaluations, there's a real tension between doing a safe evaluation and an effective evaluation. And that tension is dynamic. It's not always opposing. But we know that when we bring up trauma and when somebody tells us about their trauma, it can be incredibly distressing. And so minute to minute, we have to read our clients. They come understanding that this is an important part of the legal process, and that the more they share, the better or more effective our evaluation can be. And at the same time, we have an obligation for their well-being, and to really understand when they're in distress and can't share something, or when they're feeling stable enough to share details. And I think more often than not, our volunteers are incredibly skilled and are able to make people feel comfortable. And we often hear disclosures of things that people haven't shared before. And that can be really powerful and really important to building up their case. So this is where a trauma-informed approach is so important. If we're able to build trust and rapport, we can mitigate the risk of harm. We can reduce the distress that somebody feels around this evaluation. So I want to outline a little bit more about what's involved in a trauma-informed approach. The organization that I use as a resource most is the Substance Abuse and Mental Health Association, or SAMHSA. You'll find trauma-informed care, though, show up in lots of different places, and many of you have probably participated in trainings around this concept. And it's not a specific curriculum or specific approach. It's just a way of systematically including your awareness and knowledge around trauma in the care that you deliver. And so SAMHSA uses a 4 R's model to really summarize this. And the first of those is to realize that trauma is widespread. It's incredibly prevalent, and when you're working with a refugee or immigrant population, you can assume that most people have experienced some trauma. And so everything you do should be with that lens, or understanding that trauma is all around us. The second thing is to recognize signs and symptoms of distress. And that's about educating yourself about what distress looks like. And it may be subtle, or it may be different in different age groups or people from different cultures and countries. But recognizing then allows you to respond to that trauma. We should absolutely respond in our one-on-one conversations with people and interactions with people, but we also should respond by designing our clinics down to the policies, the procedures, and the space to recognize their trauma. And then we should actively resist re-traumatization. And this gets at some of that tension that exists for us. So if you're in an intake visit for a lawyer's office, you're probably going to have to deal with some of the traumatic events, but you may not choose to dive into some of the deeper traumas at that setting or at that point in time. And in fact, in a lot of settings, we actively avoid talking about trauma for people's well-being. There's not a need in the first time you meet somebody to discuss some of the hardest things for them to talk about. The need is to establish a foundation of trust. What's different about our work in forensic medical evaluations is it's an imperative, and we have to gain trust really quickly. We have to explain to people what we're doing and why we're doing it. And then we have to really sense that balance of trauma versus safety, and try to get as much information as we can for the benefit of the individual we're working with. Some of the components of a trauma-informed approach that we try to build into our policies, a safe environment. So ensuring somebody's comfortable. I can think of a client where we made sure that we had a Diet Coke and a bag of Doritos on hand for this adolescent client, because we had been told by her caseworker that was really important to help her to feel comfortable and to start to open up. And we also use symbols of safety, and that may be a pride flag in our waiting room. We utilize interpreters who are not only translators but cultural brokers and interpreters of culture. We think a lot about the power dynamic that exists between a clinician and an asylum seeker, especially if an asylum seeker has faced persecution with medical personnel involved, or medical personnel that ignored their complaints or didn't give them adequate care. And I mentioned transparency. So we explain our role, we ask permission to proceed, and we try to give agency to people as much as possible, some control over aspects of what they share, how they share it, or how we examine them. I also want to point out an awareness of the context of their trauma, in that there's a lot of intersectionality and people have experienced multiple levels of marginalization, and trauma doesn't end when you cross the border into the United States. Race continues to be a huge issue, xenophobia, the immigrants experience. And then people may feel marginalized within their diaspora, even if there's a large community from their country locally. They may feel as if they continue to be persecuted, or they have a perception of isolation from that group in the United States. There's lots of screening that can be done for trauma, and specifically for mental health following trauma. And I just want to highlight the Refugee Health Screener as one. The CDC has a wonderful toolkit for taking care of immigrants in a medical setting, of which the Refugee Health Screener is a 15-question questionnaire that helps get at some of the more subtle signs of distress around trauma. And I'll include a link to the CDC resources at the end of my presentation. So some practice recommendations that I can give to you. Again, whether you're in a clinical practice or a social service practice, incorporate trauma-informed care to what you do. Identify distress and try to address it not only with the way you interact with people, with this ultimate kindness, I think is the best principle around trauma-informed care. But also that you design your space, you design the process in which people interact with your organization to really acknowledge their trauma and accommodate them. Refer to legal services. I think by far the most important factor into somebody's success in an asylum claim is good legal representation. And people are very vulnerable to attorneys who are preying on them. Attorneys can be expensive, and they really need to be well served in the advice that they receive. So get a local network of legal services that you refer to. For those of you who are more clinical, I think it's worth seeking out training. And any of the places I mentioned in New York City have local trainings around forensic medical evaluation. But one of the beauty or silver linings from COVID is just the accessibility virtually to train and educate yourself. And so there's all sorts of trainings going on where you can get educated and start doing these as part of your practice. I particularly encourage social workers. I think the experiences that you have in other domains, you can really bring to the table here. And by learning some additional, something additional about the legal side of this and some of the forensic documentation, I think you can really bring your skills from your career outside of forensics to bear. Also want to circle back to the TransAmerican migration of Africans and highlight some policy recommendations. So a lot of the border practices, and I'm speaking here about the US border practices, there's certainly issues with all the countries along the way and the way they handle migrants, but currently there are a handful of practices that are really violating human rights and asylum law and access to asylum. So prime among those is Title 42, which is a public health statute, which is being used to close the border to all immigrants and to asylum seekers among those. But even before that, we saw a couple of phenomena going on. So Remain in Mexico was a policy that kept asylum seekers in migrant camps in Mexico, essentially, with very little access to legal resources or medical evaluations like this to try to make their asylum claim. And then there's been a metering process of only allowing a certain number of asylum seekers across the border. So there's a lot in the policy domain that we can do. I think making migration safer, particularly parts of that route through Colombia in particular, are very dangerous. And so trying to track migrants and give them resources along the way for safety is really important. And then addressing the racism that exists. I'm talking about racism along the migration pathway, and certainly language barriers leads to a lack of access to asylum as a mode of a safe passage to the U.S. And then there are no regional standards across all of these countries that people cross, and so entering Panama, you may receive documentation and paperwork that allows safe passage and crossing the border. But in Mexico, there's a whole nother set of paperwork. And so trying to make those more standardized or uniform would address some of the issues. And I want to close by highlighting resilience. And I do this as part of my practice every time I meet with an asylum seeker and we have, a 2-hour interview and evaluation. I close by reflecting back some of the resilience that I see in people's stories. And first of all, people seeking asylum have gone through incredible experiences to get to my office or my virtual evaluation. And they have received support from family. They've received protection from relationships they formed along the way. They've sought out education or music or religion or things that kept them safe and kept them going. And I've seen a lot of recovery from particularly severe distress. And also receiving asylum dramatically changes people's lives and dramatically changes their mental health. And in our clinic, we're fortunate to have a 93% success rate of people who have received asylum. So this past week, we just hit our 100th client who received asylum. And so we find that it's a way for us to make an impact on individuals' lives at a time when I think we all feel a little helpless addressing some of the larger policy issues in immigration. And so I would encourage you to educate yourself and connect your clients with these resources because they can be incredibly impactful to people's lives. So I'll leave some resources in this slide deck, and I think they can be sent around or tweeted out. The Istanbul Protocol, the Society of Asylum Medicine, great places to start if you're educating yourself on this topic. And then I certainly want to make myself available for anybody who's interested in learning more about this.
Wow. Yeah, really. Thank you. Thank you so very much. So very much. That was such an excellent presentation. And thank you for your work. Well, before we go into the questions from viewers, I wanted to put myself first and just ask, when we're talking about the policy recommendations, I wonder if first, if you have any opinion, which I can probably guess, but any knowledge of any advocacy around expanding the 1-year ban, talking about gaining trust from the asylee to be it the social worker or the doctor. There's just so many reasons why we need to expand the 1-year ban or get rid of the 1-year ban rather. Just wondering if there's been any movement on that you may have heard of.
I think unfortunately, the immigration rules were really going backwards. They were regressive in the last administration. And so a lot of what we're doing now is clawing back around issues like domestic violence or gang violence that were really taken away as legitimate forms of claiming asylum. But to address the 1-year bar, I think this is an area where a medical evaluation is really important because if you can demonstrate that you faced extreme hardship and that was the reason you weren't presenting within a year, then that can be negated, that 1-year ban or a bar rather. So a medical evaluation that shows that somebody's experiencing post-traumatic stress disorder and some of the heavy symptom burden that comes along with that, like social isolation or fear of going outside or fear of being around crowds. I mean, these are really common symptoms of post-traumatic stress disorder. And so in every case I've ever had, the 1-year bar has been, when it hasn't been met, the judge has allowed for it because of the medical documentation that comes along with it.
Wow, that is very interesting to hear.
I wouldn't discourage somebody from seeking asylum if they didn't meet that 1-year bar. I would encourage the lawyer to access some resources around forensic evaluation.
Yeah, wow. I think there's some advocacy there, at least in New York, for lawyers then, because in our cases, a lot of people won't even take the case because of the perceived rejection because of the law, the ban. Anyway, thank you. So yeah, everyone, we have a few minutes left. If you'd like to put your questions into the chat. And was Kenneth going to help with this? Or
we have a question in the chat from Amina, who says, what's the best way to refer clients to your clinic? And do you do extreme and unusual hardship evaluation for the cancellation of removal cases? And Amina's writing for the legal department at ASC.
Great questions. We have on rare occasions done out-of-state evaluations, but because of some of the restrictions around doing virtual evaluations out of state, we generally try to connect people to local asylum clinics. And so those universities that I mentioned earlier all have referral systems. And you can probably Google, Columbia Human Rights Clinic or Asylum Clinic and find their referral form. And I have great colleagues at all of those places. If you have clients who are, we've had people who transit from Boston to New York for work or family. And so definitely you can send an email to me if there's a unique situation. The extreme or unusual hardship piece. So if somebody's able to show that deportation would cause extreme or unusual hardship, then they can often get a stay on their deportation, or not often, that's not the right word. They're eligible for a stay. And so we have done a handful of cases, mostly with children, and mostly children with medical or psychological issues that we can document. But I work a lot with PCPs to do that, because that longitudinal relationship with a child, let's say, who's experiencing, separation anxiety because many things actually I've seen PTSD in children because their family members in detention, immigration detention, or threat of deportation. So trying to educate PCPs to play that role, I think, is a lot easier, because that's a much more common issue to address.
Thank you. Another question that we have is from Sharon Pitter, who's a community health worker at ASC, and she's asking about how we can further use our resources to mitigate the risk of trauma for asylum seekers and those currently housed in detention centers. And she's particularly interested in how we can reduce or eliminate the risk of COVID for people who are waiting in communal settings. I think this is in a question related to the publication that you had.
Yeah, this is a really challenging question. So in terms of COVID and other diseases, I've met lots of people who weren't receiving adequate treatment for a medical disorder or a mental health disorder when they're in detention. So we've played a role in advocating, and I've written reports to sort of accompany requests for parole that have been really effective. And I think, especially around COVID-19, we worked with a group in Massachusetts to release more than 50 individuals from one of the detention centers in this state. And it forced the detention center to reduce their population by half. And one of the keys was just looking at the risk of COVID spread. But another key was documenting people's medical issues that put them at high risk for severe disease. And so I think advocating, particularly those with medical diagnoses, is important. The mental health burden of being in detention is incredible. I can't speak to it enough, and I can never truly understand what it's like for those people. We have partnered with a group locally that does accompaniment, and they're clergy members that have access to visit people in immigration detention. And so I think, they provide a lot of social support to people, and it's good to match up a legal resource or a clinical resource with that social side as well.
all right, I'm afraid we've actually run out of time. That hour went so quickly. So I just, again, Dr. Gartland, thank you so very, very much for joining us today. Thank you to all the attendees. I would just like to remind folks that speaking of COVID, we actually have our COVID-19 Empower Hour on learning how to stop the spread. In English will be on the 22nd of this month, in French on the 23rd, and in Spanish also on the 23rd. Next month, for our second service symposium, we'll be speaking with the incredible Kenyan Farrow, who's the Managing Director, Advocacy and Organizing of Prep for All. Folks may heard of him in the HIV movement over the last couple of decades, actually. And then our African services, our address and information. Please join us again next month. And if we can, whether you're on mute or not, another round of applause for Dr. Gartland, please. Thank you all so much. Thank you. And have a wonderful, wonderful day.
Thank you.
Thank you.